I want to bring up Dr. Heath. I'm not going to say much. I've known her for about 30 years. My dad, who passed many years ago, said she was one of the favorite doctors that she had ever met and learned from when she lectured. And the amazing thing now about Dr. Heath is, you might not know this, last year she worked in Michigan, and then suddenly at this conference she accepted to be the new chair of oncology at Mayo Clinic in Rochester. So she's a big wig now. She doesn't talk to me anymore. She thinks she's better than everybody else. But the real reality is she's a subspecialist. She sees prostate cancer. She does the clinical trials. Her name's on almost all the clinical trials, all the major papers. She's what we call a triple threat. So she does research. She also sees patients, and she's teaching the next generation of doctors. And I'm so honored that she always kicks off to be our first speaker here. So Dr. Heath, come on up. Thank you so much for being here.
I'm not sure how to top that at all. How do you move forward after that beautiful human right there? Another round of applause for Dr. Moyad. Thank you all for just being here today. This is, and I will say it again to Dr. Moyad, this is actually the premier meeting for all of us to connect and really talk together about what's new. I know many of you follow along as well virtually, and the changes that have happened actually require many more meetings than what used to happen in the old days, which is once a year we got together and shared, and usually not with patients or families or caregivers. So what I'm hoping to do is to run through what is new in advanced prostate cancer. Many of you have actually asked me, whether I was in Detroit or at Mayo Clinic, you know, sometimes what they like is that my slides don't change too much, because it gets really overwhelming when you're trying to follow a thread of information that's happened. So I'll keep some of the things the same, but also show what's new since last year. Because for some of our return attendees, that's important. For some of the new folks joining us, it's also to understand what that landscape looks like. So I start with this slide to kind of do a level set. I'm just impressed at your lineup for this meeting. You have literally the world's experts to talk about everything from local therapy to clinical trials to all sorts of what's new. We're talking about prostate cancer in September because this is the month that we talk about prostate cancer awareness. One day I'd like to stand up at this stage, and I'm sure my counterparts would agree, where we can say prostate cancer is no longer an issue. But we're not seeing that, and if anything, as you see the death numbers, and compared to last year, they're a little bit higher, it's because we're starting to see from the lack of screening that occurred a decade or 15 years ago catch up to us. So we're seeing more advanced prostate cancer. I'm a medical oncologist, and when I see folks coming in with high PSAs and sort of, 3-year back pains or difficulty urinating and not really having a discussion about a rectal exam and or a PSA check, that's really sad to me. I think it's sad to all of you when all of a sudden you say, wait, I could have had a conversation, I should have had a conversation. Maybe I can pass that forward. So action item 1, just from this first slide, talk about what's happening. Because when you tell your neighbor or your family members or just friends, they may also want to hear from you that it's okay to ask about whether prostate cancer screening is important, whether this is appropriate. Because when found early, and most folks are, it's highly curable and treatable. So what we hope to see is getting that conversation started so early that I become obsolete. That would be lovely. That would be really, really lovely, because once you get to the metastatic advanced stage, what we are learning nowadays is that it's not just the one-size-fits-all kind of treatment. And if anything, in a good way, there's a lot of different options that's occurring now, but that makes it really hard to articulate and share with you when we're seeing you for the first time. Oh, here's a whole menu of things we can do. And you're like, I think you just need to start from the beginning. And it's a lot of information. So kudos to all of you for taking this time to really learn at least some of the words that we're saying, because when 1 in 8 men in the United States get prostate cancer, this is a conversation you're going to hear at some point. Doesn't matter if you're at the Thanksgiving dinner table, at a neighborhood party, this is going to pop up. So what do we know? We know that in 6 out of 10 men, you're gonna get prostate cancer over the age of 65. So some of those conversations that we're having also may revolve around a higher risk group in African American men. And having those discussions about family history. Thanksgiving tends to be the time we encourage people to talk about your family history. And this becomes more and more important in prostate cancer because things that affect us in the advanced setting really hinge nowadays in knowing not just your family history, but the impact of that for your next generation. So if you have a dad or a brother that had or has prostate cancer, that doubles your own risk for developing prostate cancer. And when you're thinking about that, your mind right now is thinking, oh gosh, who else do I need to talk to in my family? The risk is actually higher for a brother than it is for a dad. But the good news in all of this, and I always say, look at that last bullet, 3.5 million men are survivors. That includes all of you, so a round of applause for all of us today. Yeah. Fantastic. It's important because that is part of the journey. Because this model here, which we show over and over again, and despite multiple promises that we're gonna update this still holds, which means that it is a journey. Some of you are right at the beginning. At the clinically localized space, you just got told recently you have prostate cancer. That's several of you in this audience. There are folks that have had treatment, whatever that treatment is, and maybe you're worried that your PSA is starting to tick up again. Do I need to do something about that? And then there are folks in here in the green boxes, which is you've been on hormone therapy and you're kind of worried that things are advancing or you're presented that way. What's next? So this is a wide range. And when you talk to your neighbors and your friends here in this conference, recognize everyone's here at a different point in their journey and that the questions will reflect that. So I just want to encourage you again to interact as best you can. The way we think about it, and this is not anything you have to know, what we think about is, well, why does medical oncology even have to worry about what's happening in clinically localized disease? Why? Because when you look at this group, if you are defined as a high risk or very high risk localized prostate cancer, the conversation of having a hormone drug is already part of the picture if you're considering radiation therapy. And I'll see a lot of you in my own clinic where you're stunned. You say, I don't understand. You're going to take my testosterone away. Why? And now we're adding pills to this story. So it's really important to know that we're going earlier and earlier in your journey to try to get at this cancer so we can control it as best we can. I am impressed at, I guess, my own self for having this slide with the boxes. Many of you have seen me say, you know, I go back to the slide with the boxes because it's color-coded and it's easy for me to see the entire landscape of what is approved in prostate cancer right now, today in 2025. So the yellows are the chemos. The purple is a type of immunotherapy. The greens are what we call androgen receptor pathway inhibitors, or sometimes we call them ARPs. It's the new lingo, so you guys are now caught up. Radium is a type of treatment that is also a radiation, a fancier type of radiation. Relugolix is a new type of pill for hormone suppression. Lutetium-177 is a theranostic, and all those in red are what we call PARP inhibitors. So it's easy to see the whole swath. We're not gonna talk about every single one, and I'm not gonna show you 1,000 curves. I just wanna hit some of the highlights so that you become familiar with the language. Why? Because when we start spouting off this, it not only feels like you're in a biology 101 class, there's a quiz at the end that you're not gonna pass. That's even worse. So we don't want that for any of us. But compared to last year, what's new? Hey, Dr. Heath, there's no new boxes. There's no new boxes from last year. Well, but there's always something new. Now, the boxes don't all come barreling in, but there is always forward motion. So what's one? One of those ARPs has an expanded indication. Now you can give it earlier in the hormone-sensitive state without chemotherapy. With enzalutamide, in partnership with one of those red box drugs, the PARPs, it actually did not get approved for all comers with prostate cancer. So it's actually important to know what didn't happen. Number 3, apalutamide, another ARPI in there, actually had a generic version. We don't often talk about generics. We often talk about how expensive these drugs are. But at some point, they do become generic and more accessible to everyone. We are coming from all different states, from all different parts of the United States and beyond. Everyone's access to all these drugs are different. So when we have an approval like that, it's important for all of us to know. There is a new type of PET scan, PSMA, not the PET scan itself, but another tracer that was approved, known as Gozellix. So this is important because it expands, again, the different types of tracers accessible to you. There are many people sitting around this room that don't have access to PET scans, which sounds phenomenal. You said that's impossible. Actually, that's very possible. I practice in a rural community, so not every person next to a hospital can get a PSMA PET scan. Important, why is this one important? This has a longer half-life, which means that you can have this 6 hours away and get it to you so that you can actually get the PET scan near your house as opposed to you traveling somewhere far away. And then an expanded indication in March to include, again, we'll talk about that for Pluvicto, which is getting it earlier in the stage. So whether you have an extra box or not, you certainly have advancements every year. And that's why you guys come to this conference, because then you know what they are. We're still on the ARPI train, all about the androgen pathway, so make no mistake about it. One of the things that we are doing, and not just in everyday practice, but in drug development, we're still targeting that androgen receptor, which means somewhere in there, we are affecting, most of the time, your testosterone. So talking about these different side effects, I'm sure many of you can identify any, some, or maybe all of the side effects that have occurred to you. My plea here is tell your doc that this is happening. Don't keep it all inside, because there are ways that we can help to improve your quality of life. There are newer medications, there are newer strategies, there are things that one can do. So just be mindful of that. There we go. This is not for you to know, but to recognize all those things that populate the boxes come with data. So the data that we cite, and this is the most recent, really shows that there's a survival benefit. So a lot of times we're up there with our science and we go, hey, look at this, it's cool, boy, I sound really smart. At the end of it, hey, Dr. Heath, do I live longer if I add this medicine on board? And the answer is yes, you do. Shouldn't that be the main goal? Of course, but of course, done well, meaning we can't make the medicine worse than what the cancer is doing to a person. And that sometimes gets overlooked. I also want to say that we talk about chemo, so again, the first 3 boxes, like it's, it's a taboo thing, but it is something in our toolkit. These are standard chemotherapy side effects that are related to those drugs that I mentioned to you before. But that's not where we should focus. The question is, who should get selected? Should you get an injection and an ARPI, so injection and a pill, or should you get an injection, a pill, and some chemo? And that's the number one question I get for men who are newly diagnosed with metastatic disease. And the answer is there's a lot of reasons why we recommend what we recommend. You may look identical to your neighbor, but have different comorbidities. You might have a diabetic patient and you might have a hypertensive patient. You might have access issues. You might have the world's best insurance. No 2 man with prostate cancer is the same. And that is an important thing. What do I personally use other than these selection factors? I could tell you, and I'm so sorry, I think I'm struggling with the thing here, is that there are actually tools that we use to determine whether doing chemotherapy is the right thing for you. And you're gonna say, well, why is that? Because I'm used to working with a lot of engineers, and you know what we want? We want hard data to know if something is helpful, harmful, as opposed to the gut feeling. Not to take away the gut feeling, because gut feeling means experience. But Let's say in a hypothetical patient, you're 74 years old, you're newly diagnosed, you have a little bit of hypertension, you're mildly anemic, you got some balance issues, so you're a little worried sometimes about not knowing where that next bench is going to be and your walk, but everything else is looking great. You look on paper like you're a spectacular candidate for chemo with the ARPI and the shot, and we're all good. But if we're going to actually, you guys might have to help me with actually moving the slide because the clicker isn't super responsive. Oh, there we go. Right here, what might be helpful here is to show, this is one of the tools we use called the CARG-TT tool. And so I'm going to run this patient with, so he's male, yes, okay. Age greater than 72. He's a 74-year-old man. He's going to have genitourinary cancer. That's what fits for prostate cancer. Standard dose chemotherapy. We only give one drug at a time. But you're a little anemic, so his hemoglobin's at 10.5. Going on the right side, normal kidney function, hears very well, but he's fallen a couple of times. So what do you mean? Well, the balance was a little off. I kind of fell, and then 3 months ago, I kind of tripped. I don't know, maybe some of my I fell anyways. But I don't need any help walking. I don't need any help with taking medicines, and I'm pretty active. But if I put all of those numbers together, you can see when I do this actual scale that this person is at a high risk of having a grade 3 toxicity, meaning we might run into some real trouble with this chemotherapy. And you're thinking, how is that possible? Because there are studies that have done to back up this table that shows, you know what? We're not going to just blindly say, hey, this is going to happen to you. We're actually going to use some tools to get us to a better place. So this person might actually be just fine to do an injection as well as an ARPI. So I hope that's helpful in terms of sort of opening up the back room to say, how are you guys making these decisions? Because at the end of the day, more than an injection in this scenario is the standard of care. And I keep saying it again and again because 5 years ago, that message wasn't there. But because of conferences like this, that message is happening. So look at this study. This was just looking at 24,000 patients in a health system called Flatiron. Nowadays, 77% of men are getting their treatment intensified. That means instead of just the shot, you're also getting either the pill and or the chemo. So conferences like this, all of us talking about it helps, because we didn't do this. The number of men not getting life-prolonging therapy was at 80%. A total miss. We're doing better. So see, there is a reason why we're all here, and it's to really make sure that we're getting to what is on these boxes. Hey, Dr. Heath, how do we get the red boxes to be applicable? How do we know if we should have that as part of our treatment menu? So here's the latest guidelines. Those PARPs are for folks who have an actual genetic mutation. So you're gonna say, well, how do I know if I have one of those? That's exactly why you're all here. And I know you have a more in-depth session on this, is the entire world of prostate cancer has moved on to include molecular testing. So this is not just hormones. Oh no, chemo doesn't work. We moved on from that. So if you take away anything, remember this slide. If you have advanced prostate cancer, you need what we call germline testing. All right, we're all gonna say it together. Germline testing. That means we're gonna look at the inherited panel. What is your DNA from your mom, your dad, and what makes you you? Why is that important? Because those 4 boxes that exist right now, you don't even know if you're eligible for them if you don't check. Now that is a miss, a total miss. So these are all things that will be helpful when you ask your doctor, is this possible? And we're not gonna go through the Bio 101 lecture other than, why does this work? Because it knows how to kill those prostate cancer cells. And it's really important because these are the 4 that are approved now. These are the red ones. I don't know how they turn blue, but they're supposed to be red boxes. But they're all approved. Most now in combination with an ARPI. So not just alone, but with another agent. Why is this important? Because if you sometimes don't even get this discussed in your visit, you can be your own advocate and say, excuse me, what about the pills in the red boxes? Do I qualify? Does my father qualify? Does my granddad qualify? Are there side effects? You bet. There are always side effects, but manageable, treatable, doable. How are we doing on testing? Just like did the message go out with intensification? How are we doing on testing? Look at the bottom bullet. 62% of men are not getting tested. Now, it says somatic testing. You said, what's that? She said germline. Germline is what you got from parents. Somatic is what the cancer is doing. So we don't have enough time for me to go in depth other than that's more testing. So you can also qualify for things in the red box if your cancer has that mutation. Really important to know, though, that that message is not out yet. So that will be the next sort of bar. What if you can't have any insurance coverage? The Promise Registry is still open. You can still go on Prostate Cancer Promise and get a kit for yourself if you worry about your insurance not approving it. And they will mail you a kit, and you could do your own cheek swab and check yourself. Okay, so that's still open. Moving on quickly, for immunotherapy, there's only one immunotherapy that everybody sort of, what about this drug? What about this drug? In 3% of cases, we look in people who have been molecularly tested for a status known as MSI, or microsatellite instability. And what that means is a drug known as pembrolizumab, but all of you know it better as Keytruda, because they do a lot of commercials, and it's approved for 26 other cancers to work with your immune system. In prostate cancer, there are 3% of you that will test positive for this. It is often missed. So a lot of people will say, that's it, I have no more treatment, but they've never been tested. This is a miss if you don't test. There's no other way for you to know. So super important. The other one is known as Sipuleucel T, or Provenge. It's still around, just not as heavily used as it's been in the past. For men who are newly diagnosed in the castrate-resistant, meaning you've been on shots or shots and pills, and now the cancer's starting to take off, this is still available and is still FDA approved. So that still warrants its spots in the, but just like most immunotherapy, when you're messing around with the immune system, you could have these types of side effects of chills and fevers. Very manageable, very time limited, usually not a big issue. The other medicine known as radium is also around. This has now been around for a long time. Raise your hands if you know Marie Curie. Yes, because we've seen movies. She's talked about having the Nobel Prize, 2 of them. That's the drug that she discovered, radium. So there was that movie, I think, known as The Radium Girls. Why is that important? Because it's actually a drug to treat prostate cancer now. So people are still very much into the theranostic space. This is still a very much ready to go, available treatment for men with bone-only resistant cancer. Bone only is the catch, but still there. So again, oh no, my doctor says I have nothing left in my toolkit. This is still part of the toolkit. These are some of the side effects. And we are perpetually going to be worried about your blood counts. Unbelievably worried about your blood counts, because we are now keeping everyone longer alive. But we're doing a lot of things to you. So we have to be really careful on the sequencing. What do you do first? What do you do second? Those are conversations that your key opinion leaders and experts are having all the time. This should be first, this should be first. So you might get a little bit of that. And why is that? Because this study that I just cited was maybe 12, 15 years ago. And so how do you integrate this study with newer studies that are just getting published in 2025? And that's the difficulty we all have. because everyone will be able to spit out one of these things and go, oh, look at this. I've got survival curves. Oh, look, I have long-term data. Okay, but I'm coming into the story in 2025. What's for me? So when you have conversations, it isn't what's on the menu. How is the menu applicable to me? And how are those side effects being integrated? You all have heard about PSMA. It's really important to know that has taken up a lot of conversation, I think, both science-wise as well as these types of meetings. Oops, I think we want to go back just one. I want to highlight that the way you know if you're eligible is you need testing. So I'm not sure if somebody can, it's probably me. There we go. These are 5 agents as your PET tracers to check your PSMA. So one of the tricks would be, oh no, my insurance denied a particular one that my doctor ordered. You can be specific and say, did you order Pylarify? Did you order Locomets? Did you order Posluma? Because depending on your insurance plan, they may say yes to one and no to the other. So we've had that happen already. We go back and say, what will you approve? With those indications down below. Suspected metastases, who are candidates for initial therapy, suspected recurrence based on your PSA. So you are now empowered to ask. All of this with Pluvicto, which is one of the medicines that you are all very familiar with, is from this study. And as we think about where is this field going, it is taking off like a hot rocket. It is not just about lutetium-177. There are many other molecules now being developed to target PSMA and to also target nearby offending areas using this strategy. So is this important? You bet, because clinical trials will depend on what did you get before you showed up for the trial. That is the number one reason someone is actually not eligible. Oh, you can't get this because you've had that. So important to know for yourself what that looks like. So in this trial, people live longer. I want to be careful to say people live longer, but no one is cured. So there is this sense where it's like, oh, I got this medicine, so I'm going to be fine. Nope, it's another one of the boxes. It is going to be very helpful, but no one is cured. That means we're still on this journey. We still need a game plan. We still need a strategy. I just want to make sure that that is really important for you to know, because as we're thinking about how this particular drug area is going, it is amazing that the effort now is to move it closer and closer to the local space. So this is for folks who are metastatic castrate resistant, meaning you've been on treatment, and in this trial with an ARPI, one of those pills, and chemo. And the advancements, again, is recognizing how do we deal with some of the side effects. I know dry mouth drives some of my patients nuts. There's ways around that. But anemia and bone marrow decline is one of the big ones. So we have to be really careful and not just sort of giving you the treatment without making sure you're doing okay. If you're not doing okay, speak up. Say, excuse me, I'm not sure if I'm doing so great. Because people get focused on it. I show up every 6 weeks, you're going to give me this medicine. You might have to delay it to every 8 weeks, and it's still okay. So just be really mindful to advocate for yourself. And so that's for people who've had pills and a chemo. This trial is not just for people with pills. So, well, I've had the pills, can I get the medicine now? And the answer is yes, you can, because there's a survival benefit there as well. So in one of those updates for 25, this is the most significant update. You do not need to have had chemo to now get Pluvicto. That is a huge advancement, and it has shown all of the same perks and benefits and side effects as we've seen in those who have had chemo. So really, really important, because with this FDA expansion, you can advocate for yourself, because maybe this message isn't exactly all out there. So now you know, if someone says to you and you think, wow, in this 25, do the physicians really not know? If you don't specialize and think about prostate cancer like I do all day, every day, these kinds of little updates, it's just a, March 28th, newsflash. We have an approval update. Okay, if you are in a really big practice, there are many approval updates, which is great. You now can be the advocates for yourselves or for your loved ones. What about Pluvicto now, as opposed to after failing chemo, right? So everyone's got that. Now, you're gonna say, well, what else is happening here? Do we have other trials? I heard there were many, many trials post-1 ARPI. What if we get another theranostic, which is what this drug kind of class is known as? And this was a trial known as the SPLASH trial, and it was ongoing and accruing like crazy. But just like in everything we do in science, it's not always a home run. Now, in 2023, and I shared this with you last year, it's looking pretty good. There was an advantage for what we call progression-free survival. We got to wait for more time to pass. But this was looking like, wow, this is going to look just like the other medicine. But many of you know not every trial ends up the same. So what was the update in May of just this year? It reached 100% of pre-specified overall status or survival events. And what happened? What happened was it wasn't the home run. The way the trial was designed, slightly different than the other trial. But the bottom line is when the company, last line says, does not plan to pursue or further invest in this asset, that means this particular line of inquiry is complete. So you have a drug that worked, you have a drug that didn't. Same class. Are we surprised? No. Drugs will come and drugs will go, all depending on how you design the study. And we will be picking at this for years to come. Here's another trial, Eclipse. Last year, there's this endpoint saying that, yep, it's looking good. We saw some benefit. Okay, we will wait and see what is the final. There's no new updates for that. For Pluvicto, it's now moved on to even earlier in that castrate-sensitive space. And this trial, PSMA addition, is waiting for its final readout. It has finished accruing, and maybe even some of you in the audience has participated. So really important. But in just June, I mean, right out off the press, it's met its endpoint. So what does that mean? We started here after you've had an injection, pills, and chemo. And now today, in 2025, we can get it with pills and an injection. No chemo needed. This result just said, you know what? For you newly diagnosed folks, maybe we give it to you right now, and we don't have to wait till you turn resistant. That is going to be a big game changer for all of us. I'm not sure we know the right answer because we have to make sure that we know what to do, especially in an evolving landscape in this world of theranostics. What about another type of payload instead of lutetium? Here's actinium-225. Raise your hands if you've heard of actinium-225. Right? Not too many of you. Why is this hot off the press? Because now we're getting fancy science. We have here lutetium-177, known as a beta particle emitter. Actinium-225 is an alpha particle emitter. They have differences in how they kill the cancer cells. There are trials ongoing now to evaluate actinium. If you've had Pluvicto, you might be eligible. There's now trials to combine the two. And this is my last slide and my usual plug every time I have the stage time, which is think about a clinical trial. None of those advancements in those boxes could have happened if your peers and or yourselves in this room did not participate. I just checked on clinicaltrials.gov. Open and accruing prostate cancer trials, we are at 1,186 today. That's a big number. And those are treatment, big number. What's up and coming? Dr. Moyad's gonna ask me this question. All the trials are available. Again, back to that slide with androgen receptors. It's still all about the androgen receptors. How do we continue to kill it? Protacs are another modality where we try to kill that androgen receptor. Molecular testing might discover things in the breast cancer gene family. It might uncover different things. And another target would be P10. So that is already near completion, and we should have some readout here very soon on what to do about an AKT inhibitor already approved for breast cancer, but not for prostate just yet. Immunotherapy has now snuck back into the world of prostate cancer. We were the first with Provenge, and then we sort of faded into the background because prostate cancer has traditionally been known as a cold tumor. Now we have newer ways to target this, known as cellular therapy. These are CAR-Ts, bispecifics, TILs, all probably quite foreign words to all of you, all on studies to modulate your immune system. So I will stop now and turn the floor back to Dr. Moyad. I just want to thank everyone for your participation today and give me some airtime, and it's really a pleasure to be back. So thank you very much.
Thank you. Thank you. Thanks. I want to do 15 minutes with you because I can't let you leave without doing Q&A. That's not fair. No one escapes the Moyad Q&A.
It's the Moyad Q&A.
Let's go to slide 1. You're chair of oncology at Mayo. Where's the crown? Where's the big fur coat? This is your photo at Mayo. Any comment before we move?
Absolutely not.
All right, we'll work on that. I'll work on that with you. You need an agent. Next slide. 2 things make me wacky talking to oncologists. They use the word advanced metastatic. What does that actually mean? And when do I want to see someone like you? If I talk to someone, for example, one day they'll say, oh, you don't have to see a medical oncologist till you become really advanced metastatic bone, things like that. Other people say right when you're diagnosed. What's your answer to these 2 thoughts?
You could see us anytime. You can see us anytime. Thank you. One clap. No, you can see us anytime. Sometimes what we're helpful when you're just diagnosed isn't to weigh in as a medical oncologist, but to be that impartial third person to say, my doctor really wants me to have surgery. My doctor really wants me to have radiation. What say you? And most of the time, the medical oncologists are not that involved. The second group early on is the high risk, very high risk. You saw the way folks are sort of put in different buckets. It's important to know us then. That's not metastatic.
Yeah.
That's not metastatic. That's just high risk.
Anything you want to comment on subspecialization? Meaning to the audience, if you go to one part of the country and you want to go see an oncologist early, they'll say, hey, no problem, but that person's treating 10 different types of cancer. Do you really want to focus on someone that's primarily or only doing prostate as a subspecialization? How do you feel like that? I've never asked you that question.
You can have it all. So I'm being realistic that not all of us have access to a prostate specialist per se, but you are somewhere located nearby a National Cancer Institute Cancer Center, somewhere. Even if it's a one-time consult, to talk to a prostate expert in that center, it's worth it. Just to get the bigger view, just to get the newer view. As I mentioned before, how many of these little updates that don't change the boxes necessarily, but it changes the access to you? It happens all the time. So if you treat so many different cancers, these alerts are coming at you all day, every day. It's a lot to keep up. It's not anybody's fault, it's just medicine has gotten so big, so large, no amount of artificial intelligence tool is going to get us there. So you have to advocate for yourself. Right now, unless something drastic changes, every state has a National Cancer Institute center in their state. Even for a one-time visit, it's worth it.
These are guidelines from Canada. So I give talks in Canada when I travel. We have them in America. You know about guidelines. It's supposed to guide us as to how to treat side effects. I thought that was interesting. They published these guidelines from Canada, and I know you can't read the fine print, but for almost every single side effect of androgen deprivation therapy, it says exercise therapy. I don't hear about that, but it's in the guidelines. Every single thing, bone health, cardiovascular, it's going to be added to cognitive. Do you have any comment on that? Are you responsible for the lack of people understanding about this? What's with you oncologists? Why don't you get the word out about this?
Well, there's 2 things. Guidelines, FYI, don't control them, but they do become a reference tool, so it needs to be up there. And what happens with exercise and mental health and everything else, it goes into a bucket known as integrative. And many, many centers don't have that. So you're sort of, quote unquote, on your own, or you're at one of these events and you go, oh, you know what I learned? What about this? What about that? So number one, the breast cancer family of researchers and doctors, they've already figured it out. It's on their guidelines. So if you look at breast cancer, you see that exercise is already there. The prostate group just needs to catch up. So we're trying very hard. We're catching up much better in the last 15 years. That needs to be there as well.
It would be interesting with someone with a lot of power, say a chairperson at Mayo could possibly push this a little more.
Duly noted.
Just thinking out loud,
Yeah.
not necessarily referring to you, a chairperson at Mayo. This, I thought, should have received more attention, and maybe it did, but in my world it didn't receive enough. Metformin, a drug that costs, could be over the counter actually. It's been the #1 drug utilized to prevent prediabetes from becoming diabetics. Also, it's the #1 drug used in diabetes for type 2 diabetics. It costs maybe a penny a day. It's natural. It came from the French lilac. They put it in a phase 3 trial called Stampede. This was just published. And it said it reduced many of the side effects, some of the side effects of ADT. And it could have possibly had an anti-cancer effect, but they're going to have to look at that in certain patients. But the bottom line is it helped with a lot of side effects of ADT. Costs a penny a day. What did you think of this study?
Well, two things. I think that I love good data, and I think what they're saying is true. However, I don't think metformin is as benign as one makes it out to be. I think there are a lot of patients who can't take it due to GI side effects. So I don't think one wants to offset one symptom alleviation for another. I think the anti-tumor piece has been looked at for many, 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 many years with many, many, many studies with really no positive result. So I think going down the anti-tumor would be not the way they should go. I think there's a lot of other tools to consider.
Yeah.
What we don't know is with GLP-1 inhibitors being now so widely used, what is that going to do? And we don't know that.
Because that puts metformin to shame in terms of weight loss.
Correct.
Right, some of the newer weight loss drugs.
Yeah.
But I think this is interesting.
Yes.
Some people use it now. I think one of the most interesting thing was it didn't make the cancer worse, but it might have helped some side effects. This came from Mayo Clinic. You know, let me set this up. This came from Mayo Clinic, and everybody's always looking for a hot flash cure, and we've been fighting hot flash cures, right, since I've known you for 30 years, and you want a non-hormonal treatment. Along comes Mayo Clinic. They do this study with Ditropan, oxybutynin, which is an overactive bladder drug. It costs pennies a day, and they're reporting this massive reduction in hot flashes. What say you about this new potential treatment? Is it?
I think it is. I think, it's coming from the Alliance Group, which is a huge cooperative group. So this isn't one center, although Mayo did do a lot of the work. This is multiple centers. So you're not getting one biased view, you're getting multiple investigators. I think for a medicine that even has a different, potential benefit from that, as Ditropan's a great drug, I think this one has legs and should be incorporated.
That's awesome. Because some of the early data came from postmenopausal women experiencing hot flashes, and then breast cancer, and now prostate is utilizing it. So I didn't know you were going to say that. That makes my day. So here's my argument, because I've done talks for you and other people. I always run around, people want to hear about vitamin D deficiency, and I always go, well, wait a second. Let me put this in perspective. I'm not worried as much as any other person about vitamin D deficiency. I'm worried about a D deficiency that no one talks about, and that's not enough men are getting DEXA scans. In the last database, only 8% of the men that qualified for a bone mineral density scan got it while they were on hormone therapy. So the real deficiency going on is not enough men are getting their bone mineral density done. Is this true? Do you push bone mineral density, DEXA scans? What say you?
Yes, it's true, and yes, you should be getting one at least as a baseline, especially when you start ADT therapy. The second deficiency is the follow-up. So many of you who are on more than just your allotted 6 months, 2 years, this is something that you start to see bone loss after 6 months. So you need another one. Now, the insurance companies won't technically let you do one unless it's been about 18 to 24 months. That's usually what the timing is, and that's probably right. But the deficiency, number 2, is that you're not getting a follow-up. For those of you who are metastatic and either resistant or sensitive, you should be getting them every 2 years. So we know that you don't have ongoing bone loss. Okay, so
That's
second
awesome.
message, do a follow-up.
Thank
and
you.
for just maybe a lot of them don't know what it is though.
Yeah, so a DEXA bone mineral density, because in women's health, you know what it is. In order to diagnose you with osteoporosis or osteopenia, you have to just go into a 10-minute little device. It's an imaging device. It's an open device. It has 10% of the radiation of a chest X-ray. It's very safe. It takes about 10 minutes. They look at your hip and your spine generally to tell you how your bones are doing. And women are doing this when they're going through breast cancer treatment. It's a no-brainer, but yet we have virtually no men getting this done and asking for it. And even if you got to pay out of pocket, it actually costs less than dinner in Los Angeles now. It really does, right? I mean, it's gotten pretty
Not
cheap.
in Rochester, Minnesota, but for sure,
Yeah.
LA, absolutely.
You talked about germline or genetic testing. So what you're born with certain genes. They can test that for BRCA1, BRCA2. Then you talked about somatic testing. They can test your tumor. You can do liquid biopsy. So we talk about this and this. But this is what I'm learning in other cancers.
Yeah.
Other cancers are doing both.
Yeah.
And sometimes they find a mutation in what you're born with, and sometimes they find a different mutation in your tumor. And to some drugs in those other cancers, the patient's getting a bigger response to those drugs. So my question is, why don't do both when you're dealing with an oncologist? And what do you think about this idea that, because some people are getting somatic testing without getting germline.
Right.
So anyway, that's my...
Right. So the answer is both at the right time. That's
Okay.
probably the right answer, right?
Okay.
So if you are a very high risk, no metastatic, but now you're coming to see me for additional RP pills, you should get germline. But to get somatic, number one, won't be covered by your insurance because you're not metastatic. And number two, doesn't help you with the hot moment. There you would do germline to make sure that there's no future impact to your care, but also about other family members, either brothers, sisters, or kids or grandkids. But if you're metastatic to begin with, you should get both. I also want to clarify, germline is a one-time type of test.
That's a good point.
You don't keep testing that, but know what you got. So you're going to say, well, what does that mean? Well, there's a lot of companies that will say, we just want you to check for BRCA1 and BRCA2. But most companies are now testing 88 genes. So it's the most wanted on your post office, like, I don't like that gene, I don't like that gene. The breast cancer gene itself has 14 ugly cousins. So some tests don't check it. So number one, know what your test is. Number two, get your results so you have it as part of your medical records. Because guess what? These things tend not to get uploaded in the EMR, in the electronic medical record. Okay, that's a one-timer. Your somatic, you can get every time your drug doesn't sort of behave and it doesn't work anymore.
Thank you.
You get it again.
Not just one and done.
You get it
Sorry.
again. Okay.
All right, sorry, I got you all excited. You talked about immunotherapy, so Provenge is still there. The idea is to use it as early as possible when you become castrate resistant, hormone refractory, whatever we want to do, right?
Yep.
But then you talked about this MSI test that then you qualify for Keytruda.
Yep.
But how do I get this test to see whether or not I qualify for this drug?
When you do your somatic testing, it's usually part of that panel.
Okay.
Aha. So, again, know what the test is. This is now the Wild West in terms of somatic testing. Everyone's got their favorites, but even within one company, there may be 8 different things you can check. So some just do 10 genes, some are 40 genes, some, I don't know why they're doing this, they check your entire genome of 22,000 genes. So this type of testing is very complicated. Worse yet, you get the results back, and a lot of calls I get is, can you help me interpret what this means? Because it's so hard, 30 pages, and you're not sure what the test is telling you. So it's 2 issues. One, advocate to get tested. Even if you're not sure if it's one or both of the other, say, what about molecular testing? That's a good conversation starter right there.
So when someone comes back, have you seen someone come back with this MSI high, and then
Yeah.
you give them Keytruda, which has 41 FDA approvals for 18 different types of cancer? Do you see them respond in general?
Absolutely.
Absolutely?
Absolutely.
Absolutely.
3% of you will respond gloriously. Gloriously. I had a patient with a PSA of 1,000, went down to 2.
Nice.
The issue is it can't hold it, right? But that's okay. If we can get a period of time where your PSA and your cancer is controlled, thumbs up. But this is where you don't get upset, where you're like, well, I'm not this. I just told you, it's 3%. That means 97% of you won't test positive. But if you're that 3%, it's another box that you can check in your toolkit.
Great.
So why not?
CAR T-cell therapy. Man, you came to this conference a couple years ago. We were all
Yep.
excited about it.
Yep.
What happened to it? And now I saw a press release in the past few weeks about forget CAR T. There's this new thing at UCLA and other places called CAR NK, natural killer cells.
Yep.
And it's a lot cheaper to do, and it might be more effective in prostate. What do you say about this? What is this, and what do you say
Yeah.
about it?
So let me just say, when you're thinking about what's happening, what's the bucket of cellular therapy, it's not going after the cancer specifically, like chemotherapy and all these other agents I was talking about. This is us trying to tell your immune system it keeps missing the bone metastasis that's in your system. This is us telling your liver that those cancers don't belong there. But to do that, it's worked exceptionally well in liquid tumor patients. So lymphoma, leukemia, multiple myeloma, you can mess around with the immune system, reprogram it. In the solid tumor case, it's a little harder. And this is very huge field where you're basically re-engineering your immune cells to recognize things in a much more thoughtful way than your other medicines like Keytruda and so on. They all work differently. Most of these trials will combine it. So what's the downside? There's a lot of side effects because you almost have to wipe out your immune system to begin again. So this is a different view. It's not for everyone, but there are derivatives of this coming, such as the bispecific antibodies, targeting a part of your immune system. So this part has completely exploded. Why is this important? Because a lot of trials are looking at the different targets and also different drug delivery. So if you feel that, oh no, I don't know if this is right for me, just ask, because this may be the right next step.
Pluvicto you talked about. I'm excited about it, but I'm excited in urology. There's a trial, for example, it's going on where they give it in a trial before surgery.
Yep.
So these are people who are still sensitive to hormones to see if they can help downgrade the tumor or wipe it out.
Yep.
What's next for Pluvicto? I know the side effect there is dry mouth. We always freak out about. So that's the quick question.
Yeah.
What's next for Pluvicto? Is it just moving it earlier?
And maybe longer. So the next big trial is not just you stop at 6. So many of you said, why am I stopping at 6? I still have a PSA, I'm still responding. If this was chemotherapy, you'd go on for another 6. So the current trial now is you go for 12. So that is available, and there will be many more. And then of course, hey, doesn't Pluvicto need a friend? So there's a lot of combination studies as well to try to get at that quickly.
And the next drug that might even surpass Pluvicto that you talked about is actinium.
Yeah.
It's the same, it's a radiopharmaceutical. Is that going to be the next FDA-approved medication? And hold on, I got to get my financial advisor on the phone.
Yeah.
No, it's not a stock tip. I always like people to predict. Are you feeling good about this possibility? Because there's a lot of these trials going on that are moving.
I am feeling good about this possibility. Alpha emitters in general are really, I think, very, very active. The side effects will be the thing to watch for. As any one of you can imagine, powerful drugs come with powerful side effects. So the trials will probably not finish for another 2-3 years. So this has still got a while to go.
Here's a couple trials of chemo. Next slide, let me just summarize this. So you all get excited about 2 chemotherapies, Taxotere, and the other one's Jevtana. But I always find it interesting that the first one that you give has more neuropathy, nerve issues, and it causes hair loss, but the other one doesn't. So why is this just a breast cancer issue of losing hair and these nerve issues? Why not give the second drug first instead of the first drug that's more toxic?
Yeah, data and insurance approval. Many of us would love to give cabazitaxel first. We absolutely would. Can't get it cleared through your insurance.
Okay, but then what about what they're doing in breast cancer to stop the nerve? So during the time of chemotherapy, they give them cold caps, they give them cold socks, cold gloves, because it cuts off the amount of drug that goes to those areas.
Yep.
And so why not just let them put their hand in ice or their feet in ice or something that's cold during the time of chemotherapy? Are we doing that?
I think it's available. I think it's the infusion itself for 60 minutes. So you stick in your hand in a bucket of ice for 60 minutes might be somewhat challenging, just putting it out there.
Yeah.
It is available, so at Mayo Clinic, for example, we have that.
You can
but
do
there's
it.
also a whole thing where you can try to cycle it based on the chemo administration. So you have to start it, and then it goes through, and you're still in it, and then you finish, and you're still in it.
I
So
just don't know why.
It's a whole algorithm.
I don't know why this is not offered to everybody. I don't get it.
And sadly, it's also an insurance issue, so I'll just plug that for all of you to advocate for.
Well, then stick in insurance. Ice is free. You know, I mean,
Yes,
that's,
well, there are a lot of my patients that will suck on ice for the whole time.
Okay, the other thing is we have these other chemos out there that are doing some good stuff in other cancers. Are we going to see another chemo drug come along?
I think not. I'll be honest
That's
with
honest.
you.
Okay.
I think not.
Okay, this is the end part. What am I missing? What's coming next? We talk about ARV-110, these things that degrade the androgen receptor. Yep. I'm really excited about that. I don't work with any of these companies there. So, what else, Dr. Heath? I mean, there's a couple other drugs. Is this the category you're most excited about that we should be watching? What's your take home one more time on that?
So I think, again, anything that goes after the androgen receptor is still all in play. Much like in breast cancer, it's all about the estrogen receptor. We still haven't deviated from the androgen receptor. The newer version of the ARV-110 is the ARV-766. All that means is we're going to keep going like this to the androgen receptor until it cries uncle. So that's one, and I think those studies are really looking very promising. Checking on molecular testing is, again, to look at PTEN loss. So if you say, what else am I going to look other than the BRCA family and the MSI?
Yeah.
PTEN loss, because AKT inhibitors are oral drugs that are already approved in breast cancer, and we tend to take the lead from the breast cancer community. So my sense is that's
cool.
going to mature sometime very soon.
I like that. I like that a lot. Next important question. Is it true you're heir to the Heath candy bar fortune?
Absolutely false.
False?
Thank you very much. Yeah.
No wonder
They
you
taste
never
really
buy
good,
me anything. Okay. So you have no relationship with the Heath candy bar?
Full disclosure.
So last year when we gave out free Heath candy bars, they made money, you didn't make any money.
None. But
I just have to understand conflict of interest here. I've talked to the most brilliant team in America, which is the PCRI team. I said, this is not appropriate. I knew her 30 years ago when nobody knew her name, and now she's the big wig, the big hot shot at Mayo. We need to do her a favor and fix this up. So I thought, how about this as your Mayo slide next?
That is awesome. I'm going to gift that to my husband.
You should.
So he knows exactly. Yeah, that's perfect.
But we thought you might
Thank you,
this is too much except for your husband.
Yeah.
And so maybe we'll just kind of a midpoint. Do we have the other one? There. How about that one? So at least you get the white coat and the stethoscope. And as we finish here, and we'll come back a little bit after 10 o'clock, I have to give you your gift. For those of you who have not seen Dr. Heath before, she is the luckiest person in the world. She's received the best gifts of all time.
That's true.
We gave you an Oscar a couple years ago.
Sitting in my office.
Right? We gave you a coffee cup that said that you're cancer's biggest nightmare, and you like that? Is that in your office too?
Yes, that's in my office.
Okay. How about a scepter?
Wow! I love it! Oh my gosh.
Yes, it was extremely expensive. That's a blue diamond. And we thought, well, if you can't use that at Mayo, I'd use that at Mayo if I was the chair. We got you a Hollywood Walk of Fame, Dr. Elisabeth Heath, signed here, so you have your own Walk of Fame that you can put up in your office.
Thank you.
Thank you, everybody. Alex,
thank you.
Thank you so much. She's going to go in the back room.
I'm in the back room.
She's going to use the scepter, and Alex has an announcement, and we're good.
Okay.